All right. So again, just to touch on that point for the people who are watching the recording, we're going to touch on the medical emergency side, and again, mainly focusing on the pre-hospital approach and our treatments available, not going into a bunch of stuff on pathophys. This is going to be a pretty quick one because it's the stuff everybody is well versed in. So looking first at neurologic emergencies, describing the types of assessments that we can use in the pre-hospital setting, as well as what we see a lot of, the big four that we see a lot when it comes to looking at patients who are having a stroke or a possible CVA. We have the FAST exam. So everybody knows that one. We've got posters up all over hospitals to everywhere else, the face, arm, speech time. Again, nobody misses those big ones, the facial droop, the arm drift, slurring of the speech, etc. And then we have the Cincinnati pre-hospital stroke scale. These are probably the two most common we see in the pre-hospital setting. The Cincinnati just basically adds in a couple of things as well, but it's pretty much a FAST exam as well. And then the Los Angeles pre-hospital stroke scale. One of those three is pretty much used by every department, but most places use either the FAST or the Cincinnati. Now again, the LAPSS adds in some other dynamics, mainly focusing around things like blood sugar and things of that nature. Okay. Now the MIND exam is a little bit more detailed. It's kind of an in-between from your FAST or your very simple exams all the way to the NIH, which is more of your obviously in-hospital, very detailed approach. The MIND is pretty much kind of an in-between point. Now with the MIND exam, I only know, at least in our area, one service that regularly uses the MIND exam, and that's Freeman Ambulance. And then that's going to be, they're associated with Freeman Hospital, obviously, which is a level 2 stroke center. So they're the ones that kind of push the MIND exam. So that's one that honestly you don't see a ton of in the pre-hospital setting, but it is something if you should run across it. It's a good little exam. It's quick. It is more steps and more things to check than your simple exams like the FAST, but it does take into account some of the assessment properties for large vessel occlusions and things of that nature. So, and obviously the NIH is definitely going to be your in-hospital approach, more of a neurologist approach. This is not something we're going to run in the field simply because of the detail of it, the time, etc. This is just not something we're going to have the pictures for them to do and show what's happening and all that kind of stuff. So, all right. Now, your different types of seizures and their treatments, again, multiple types of seizures you have, tonic-clonic or grand mal. That's going to be, your full, where they're going to be basically unconscious, they're going to have convulsions, etc. Typical treatments for that. Pretty much the treatments for your tonic-clonic seizures in the pre-hospital setting are going to focus around basically stopping the seizure. Now, most places do it with benzos, whether that's Ativan, Versed, Valium, etc. If you, from a real-life perspective, if you're going to have an IV line on someone who has epilepsy or seizure disorder, you should probably stick to a forearm. And if you can get on the back of the forearm, even better, because should they, pull in and have decorticate posturing, all right, you can have access, but at least a forearm where they're not going to kick it off in the AC or a hand. But we do have options with MAD or mucosal atomizer devices where you can put your Versed or your benzos into your MAD device and they can go intranasal, and you can get the seizure stopped that way. Those are some other options. And then obviously the simple stuff still applies. Just try to reduce harm to the patient, move objects out from around them, whether they're next to a table or a chair or something like that. Keep their head from striking the ground. Some kind of padding, whether it's a, roll up a t-shirt or a sweatshirt, or, or if somebody just holds it, just keep it from striking the ground or other objects. And still, we put nothing in the mouth. So if you run across that from a testing perspective, nothing goes in the mouth, no bite blocks, nothing like that still. And then basically your other things, absence seizures, simple partial, complex partial, the absence ones where they're kind of space off, for just a little bit, they kind of check out. And you have your simple and complex partial. You have things like where they'll do like lip smacking, and they'll kind of, again, space off for a minute. They'll might be, even your simple partials might have single movements of certain limbs, etc. So between those two, again, usually not between your absence and then simple or complex partial. Any of those things, we're really not going to aggressively treat them because normally they're not in a full tonic-clonic or like a grand mal seizure where they have issues with hypoxia and they're burning through all of their glycogen stores and oxygen and everything else. So we're usually not running into issues so we're not as aggressive with the treatment. Okay, but you need to be prepared to have maybe I'll have them on a little bit of oxygen, have a good quality IV access in one of those sites we mentioned, and be prepared should they progress to a more advanced seizure and you need to handle that or intervene. All right, and then status epilepticus and what treatments are available depends on what you're looking at, but your typical kind of definition for what is status is going to be patients who have a seizure. They go in their tonic phase, they come out of their tonic-clonic kind of phase, and they're in that post-sequel phase, but they're not in it for very long, and they never regain consciousness and go right back into another seizure. If they have that kind of pattern, or if they go continually, depends on what you look at, anywhere from 3 minutes, 5 minutes, maybe more. A lot of things you read tend to stick around the 5 mark, but if they have a very prolonged seizure that is just remains, then unfortunately, a lot of times benzos might work, but you need to be ready, and if it's an option in your service, to look into RSI. If your benzos can't stop it, you need to look into the RSI process, and then properly sedating them and paralyzing them, and then getting an airway in place, get them intubated, and then they can go from there. We get to the hospital to obviously do EEGs, etc. They can kind of go that route, but we have to establish some kind of airway, because if they stay in the situation they're in, they'll end up with an anoxic brain injury and things of that nature. So keep that in mind. If that's not an option at your service with RSI or something like that, then it's one of those, that might be your criteria for either an air medical transport, or if you're in a larger city, or something like that, you got multiple hospitals that are close, take them to the nearest facility where they can perform the process. But if that's not an option for you, okay. All right, upper versus lower GI bleeding, pretty simple from what we're looking at from an assessment perspective. Upper GI bleeding, you're going to have you typically bright red blood and your vomit, or either dark tarry stools, which is the blood and your red blood cells attempting to be digested by your GI tract. And it's going to be opposite for lower. You're going to have bright red blood and things like that in your stools, and you'd possibly have some dark kind of coagulated blood that would be coming from emesis or vomit. So again, from a GI bleed perspective, from the pre-hospital setting, obviously we're not surgeons. This is going to be something very simple. It's going to be basically position of comfort, some pain management, obviously IV access, some fluids, and if it's severe and you have the option for blood products, which is fairly rare unless you're kind of in the air medical industry, there are some places that are starting to do some blood products in the pre-hospital setting from the ground side, but it's more of a like a supervisor truck roll, or some kind of first response vehicle that will rendezvous with the truck, etc. But should that be an option, that's a treatment option available if you have the skills and the protocols for it. Now, common pain management techniques and pharmaceutical interventions that are seen in the pre-hospital setting for abdominal pain and other abdominal emergencies. We kind of mentioned them, not a ton. Positioning is one, position of comfort. Obviously, IV lines, 1 or 2 if you need to, fluid management. Again, if you have options for blood products, that's great. the debate comes with pain management for abdominal pain. It is an old school that kind of approach that is kind of gone by the wayside, but the old approach of you don't give pain meds to abdominal pain because they can't adequately assess them. Well, that was true when we didn't have routine use of things such as CT and ultrasound and all this kind of stuff. But that's pretty much gone by the wayside nowadays. Every once in a while, you'll still hear that perpetuated a little bit, but we can properly assess for things like, a ruptured appendix or, appendicitis and other GI issues that might cause abdominal pain. We have, better imaging, everything else where you can give your abdominal pain patients some pain management. That again is not something that we hear a lot of, but some of your people who've been in healthcare quite a long time might still kind of have that approach because it was ingrained in them for a long time. Okay. GU and renal. The biggest patients we're going to pick up in regards to this are going to be patients from a dialysis clinic or a center usually. And the couple of main things you're going to run across or potential problems. The first one is probably hypotension. And usually that might have been an issue where too much fluid got pulled off, or, there may have been, maybe they're having some a little bit of kind of a reflex hypertension from the dialysis process, et cetera. It is something where you can pick them up, start an IV line, but you need to be very judicious with your fluid management because the whole reason they were there for dialysis obviously filter out, toxins and stuff that have built up, but they might also be pulling some fluid off, and they might be putting some on. So obviously they're between the nephrologist and the dialysis clinic and everyone there, they kind of know the process for kind of what works for them and what their treatment plan is, et cetera. So we don't want to be running a bunch of fluids and treating them like your typical, hypotensive patient, whether that might be from trauma or sepsis or anything like that. So be judicious with the fluid, ask before you leave what they kind of recommend with this patient, if they want to have a small bolus of 250, 500, whatever it may be, and that kind of thing. It never hurts to ask your individuals there at your dialysis center what the treatment plan is. Another very common one is hemorrhage from their fistula or their shunt. So they're usually pretty good about this, but if it's still uncontrolled, you want to look at, obviously direct pressure comes first. The dialysis clamps that they have, those hemorrhage clamps that they have there at the dialysis center work great. If you don't have those on the ambulance, they're probably already going to have one on, but if they don't, make sure to ask for one. And so those are always good little tools that you can use. And then potassium imbalance, you can have this issue again if some of the dialysis was not didn't go as well as planned or something like that. Or they're having some issues. Then with your potassium, we're not going to be treating them really in the field or in the truck for major potassium imbalances. You're just going to really want to watch their EKG to ensure they don't have any type of arrhythmia that comes with it, with their electrolyte issues. Obviously, if they tell you that there's a potassium issue, you probably want to pay a little bit closer attention to your T waves, but mainly looking at your EKG overall, making sure they're not going to go into an arrhythmia, and that's basically what you're there to monitor for. And then your other typical treatments, have an IV line ready to go. Again, you may not be able to, you may not be using it, but you want it there should anything come up. And the last thing that you might see, I shouldn't say it's common, it's pretty rare, but if you run across it, it is serious and life-threatening, and that's an air embolism. Obviously, that's something we really want to avoid from the dialysis patient, but it does happen sometimes. So again, air embolism, this is, again, nothing we're going to be able to really treat in the truck, rapid transport, and then all of your kind of typical therapies to treat them. So, all right, a gynecologic, how do we treat a patient with significant vaginal bleeding? The biggest thing, and from a registry perspective that you'll see, is nothing we only do either pads or any type of external dressings to help control hemorrhage. We do not, nothing gets, no gauze, anything like that gets packed into the vaginal vault, anything like that, but we don't want to, that's not our job. So in nothing, we just want to use padding on the outside or gauze or anything like that. So from a registry or testing perspective, always ensure that. And then it's a little bit different if you're dealing with your OB patient. Again, we're not obviously usually padding on the outside, but you're going to have other issues. If a woman's just giving birth, you're going to have options like fundal massage. And if you have options for, Pitocin or anything like that, but again, that's a service dependent, protocol dependent thing. And that's on the special populations. We'll talk about that a little more. The other thing with significant vaginal bleeding is we have to monitor for hypotension and basically hemorrhagic shock. And then again, your normal treatments, your O2, IV, fluid boluses to keep pressure up. Again, if you have the blood product option, then that's great. You can evaluate that if you feel that they meet criteria. If they've lost enough blood, then by all means, go ahead and administer that. All right, special concerns, assessment and management when caring for a suspected sexual assault patient. And this typically falls, and we will mention it, but it typically happens more to women than it does men, but it is something that anyone can be sexually assaulted. So from the general perspective of being a sexual assault patient, if you have to respond to something of this nature, the biggest thing is being able to obviously be professional with the patient. It's typically what their preference is. If they would prefer someone of the same gender to assess them, care for them, etc. That tends to be a normal finding, and we need to respect their decision on that or their wishes. The other thing is you want to approach them in a way that you're there to help them. Obviously, we're not there to injure or harm them, anything like that. You also want to try to not coach them necessarily, but to lead them down the route that if they go to a facility, you want to transport them somewhere. If they have the option for a SANE or a sexual assault nurse examiner, transport them to that facility that has a SANE nurse. And then as well as you want to, where we're not PD, but you want to try to do as much evidence preservation as possible. A lot of these victims will want to, they'll want to go home, they'll want to shower, they'll want to do things like that. But again, we can't stop them, but that is something where you remind them that is where the evidence is, possibly things, epithelial cells under their fingernails, etc., hair, all that kind of stuff. So that is something where you want to keep that in mind. But for the most part, be prepared to take your time. You're probably going to have longer scene times. You're going to want to move a little bit slower with everything you do. Obviously, if they're stable, that's the case. If they're unstable and they're having significant problems, then obviously we're going to do our normal thing and speed it up, get them to a facility that we need to. But a lot of things come into play here, but some things to keep in mind. All right. Some endocrine issues, assessment and management of a patient with type 1 and type 2 diabetes. So we all know the difference. One, basically, the type 1 does not produce any insulin, and then type 2, they become kind of resistant to insulin production and things of that nature. So, and then obviously type 1 is what people typically call early or child onset, and type 2 is more of your adult onset diabetes. So the biggest thing is almost all of your diabetics know themselves better than anybody. They've been living with it so if they're type 1, they've been living with it usually for a long time. So they know their insulin, their amounts that they take, etc. And then obviously Type 2, they're probably going to be more initially on more of your PO meds, things like metformin, etc. And then they might be on some insulin as well, usually some longer acting stuff before they do as well. So biggest thing with diabetes that we're now seeing is treating patients with hypoglycemia, and that is we're kind of seeing a very big trend and shift away from D50, and we're seeing a very upstroke in the trend of using D5 in, you know, like a little 100 bag of D5, 50 or 100 ml bag. We're not really doing the D50 push anymore. You might still see it, but most places are going away from it for a couple of reasons. Number one, it's usually quite a bit at first, but you know, and they get the big kick, and then they kind of fall a little bit quicker. With the D5, they don't. It's not that as much of an instant kind of reversal of their symptoms, but at the same time, it's going to last them a little bit longer. They're still going to burn through the sugar, but it's not as much of a shock to the system. The other big issue is tissue necrosis, making sure your IV line is patent, etc. Because you know, you get into pushing that bigger syringe of, you know, D50, and you got a small vein it's not doing. It's kind of right on the border, and you push it too hard, too fast, you might possibly blow the vein, or if it's not a good IV, something happened. We don't want to just push all that into the tissue and have issues with possible necrosis. So most places are moving to that D5 approach. So I'm not sure. We haven't gotten a ton of feedback from some of the most recent groups testing. I haven't gotten a ton of feedback in regards to what they're seeing on National Registry, but I know from a practicing standpoint, we're moving to the D5 approach, not so much the D50 approach. Right. And so Cushing syndrome, we kind of all know about that. We'll let you guys touch on that. Basically, again, well, there's not a ton we're going to do from the pre-hospital setting for Cushing syndrome. Again, just mainly looking at your supportive care. A lot of your medical emergencies, when you get into specialized things such as, you know, Cushing syndrome or hematologic or immunologic issues and things like that, we're very much a supportive care kind of entity that stabilizes and then prepares for worst case scenario. And if nothing happens, then we sometimes feel like we don't do a whole lot, but that's okay. So from the pre-hospital perspective for something like Cushing's, we're just going to basically do those supportive care, O2 IV monitoring, but we need to watch out and be on the lookout for and be prepared should they decompensate by any means. Obviously, that's for everybody, but just keep that in mind. Sickle cell disease for your hematologic side. Biggest thing here, obviously their red blood cells are not correctly shaped. They're in more of the moon shape. They're not in that kind of oval life raft shape like they should be. And the biggest thing that comes from some of these are some of your sickle cell crisis, like a splenic sequestration syndrome and things of that nature. So they can have issues where they're prone to blood clots. They don't transport oxygen very well, obviously, because they don't have very much sites for hemoglobin, et cetera, on the red blood cells. So they don't have as high affinity to oxygen. They don't have as many transporting sites, all that kind of stuff. Again, all the stuff we know, but from the pre-hospital perspective, again, it's fairly supportive. You need to be prepared to administer O2, but maybe even larger amounts, depending on, you want to watch for hypoxia with these patients. So O2 possibly might need to lend yourself or lean toward high flow O2. Pain management's another one. A lot of these patients have significant amounts of pain, whether that's from clots or splenic issues, whatever it may be. So be prepared to administer some pain management drugs, try to keep them comfortable, because there might be already be in pain, and then we're going to load them in a truck and bounce down the road. And we all know the ambulances aren't the the smoothest rides all the time. So just something to keep in mind. And then some things to watch with blood transfusions, obviously from the nursing standpoint, and where you guys work and already are in this field, you know what to watch for any type of transfusion reaction, how often to take vitals, etc. From the pre-hospital approach, this is something that most states, your standard paramedic licensure and working on an ambulance does not allow the administration or initiation of blood products unless you have some special training. We are starting to see a shift where places are starting to get it, but it's typically found itself more on the air medical side from initiating blood products where it's seen in the paramedic practice. Now, personally, it is one of those things. It's just a matter of getting some education, but the logistics side to carrying blood products is probably the bigger issue, which we'll talk about a little bit. But you'll see that in the trauma approach and the writing assignment with the blood products and carrying it. So we'll touch on that a little bit more there. Biggest thing, obviously, if you, from a testing perspective and even real life, usually from the paramedic approach, we pick up patients who already have a transfusion started from the EMS approach on the ground side, and you will be transporting the patient where it's already been started, and you're monitoring it. So you're looking for your signs of the transfusion reaction. Obviously, any type of allergic reaction, you might see anaphylaxis, respiratory issues, shortness of breath, all that kind of stuff. The first thing, if you suspect or notice a transfusion reaction from a testing perspective, is you stop the blood transfusion and you disconnect the blood. You don't leave it hooked up. You stop the infusion and disconnect, and then go about treating them like you would your allergic reaction or anaphylaxis patient. So I will tell you, we have had students who've had those kind of questions on the exam, and that is by far the answer we give from a National Register perspective, which is stop the transfusion, disconnect the blood product transfusion, and switch to some kind of basic fluid, normal saline, LR, and then go about your treatment for your anaphylaxis. All right. All right. Immunologic, compare kind of signs and symptoms of an allergic reaction with those having anaphylaxis. Pretty simple. Allergic reaction is just basically, obviously, your more mild symptoms. You might have, most common thing is urticaria or hives or some kind of skin reaction. They might develop even a mild shortness of breath with it. Your anaphylaxis is going to be more of your life-threatening approach, airway edema. They're going to have the feeling of the scratchy throat. They're going to have tongue swelling, lip swelling, laryngeal edema, etc. So, and then treating those, obviously allergic reactions, things like EpiPens or epinephrine IM injections from providers if they don't have an EpiPen or haven't already taken one. Steroids, things of that nature, IV, get some fluid in them, that kind of thing. Anaphylaxis, you want to be a little bit more aggressive in your treatment. You might even do some initial IM epi, maybe even IV epinephrine administration for anaphylaxis. The biggest thing with anaphylaxis is be prepared to intervene on the airway side. So you have to watch for and be prepared to possibly intubate. And if that's going to be the case, you need to do a little bit more planning ahead. And if you feel that the patient on a normal day would be let's say it's a 7.0 tube. So let's say it's an adult female, 6.5, 7, something like that. You would normally go say a 7.0 tube, but they're having an anaphylactic reaction. You want to go at least a half size, maybe even a full size down from what you think would be a normal tube size to account for any edema. I'm not the biggest fan of using a bougie on every intubation or kind of everyday things, but any type of edema, anaphylaxis, peds with things like epiglottitis, etc. A bougie is a great tool because it's very small, slender. You can get in there, keep your landmark, and then put a tube over. And well, if you can't, if that tube's a little bit too big, or you get in there, oh, they got more room, you can exchange it. Hence why the bougie was created as a tube exchanger, but they're a great tool for things like this, where there's any type of airway malformation, possibly from edema, trauma, anything like that. So something to keep in mind if you're going to progress to the intubation side of the anaphylaxis patient. All right. All right. This day and age, this is definitely a section in regards to infectious disease, proper PPE, everything else. Obviously, I think this is in the last couple of years, everyone is well versed on how to use don, doff, PPE, what criteria needs certain things. So basically, just know your stuff when it comes to direct, indirect kind of contact, droplet, airborne, things of that nature. So, and from the paramedic perspective, it's going to be really no different than the nurse side. Obviously, we're wearing masks pretty much on every patient contact. I don't know. I know the company I'm currently flying for, they moved to an N95 on all patient contacts, regardless of COVID status, that kind of thing. But they are your typical, from a testing perspective, approach. Obviously, gloves for everybody. And then if it's a droplet, you're going to want mask and eye protection. If it's an airborne transmission, things such as tuberculosis, then you're going to want some kind of particulate respirator, N95, along with your eye protection and gowns and gloves, etc. Again, we know about the PPE, and then looking at pathophys assessment management of a patient with sepsis. From the pre-hospital perspective, obviously, there's going to be a lot more stuff done in the hospital. From the pre-hospital perspective on sepsis, if you know or suspect or know they are in sepsis or possibly septic shock, obviously O2 or possibly airway management if needed. IV lines, this is usually the patient who's going to get lots of fluids, whether that's saline, LR, whatever it may be. Usually larger amounts of fluid. They have that widespread kind of vasodilation. We want to, possibly look into a pressor as well. In most places, for sepsis and septic shock, Levophed is still the preferred pressor. In most places for that, if your service or something contains or uses otherwise, then so be it. That's fine. I've also been in that situation. A lot of us have, where your option is dopamine, or dopamine, because that's all the only pressure you have on the truck, and you're going to make do with it. I don't think it's the best option for certain things, but you have to work within your protocols of what you have sometimes. But so aggressive fluid management, as well as you need to look to some kind of vasopressor, usually after you've adequately volumized them to progress on that type shock. Now, the antibiotic administration, that's again going to be service and protocol dependent, if you can administer antibiotics in the field. But it is something, even from a field perspective, if you can, but you suspect sepsis or septic shock, then, or haven't known, you would want to obviously collect blood cultures and stuff like that. So most of the services that I work for don't really do that. The ones that did, though, had stuff. There was a hospital-based service, and we would routinely draw blood on scene and drop it off at the ER, so they'd already have it and labeled. We'd also had blood culture sets, because if we were going to administer kind of your broad spectrum antibiotic, that kind of thing, for something, then we would go ahead and draw cultures if we suspected obviously some type of sepsis or infection. So again, that's totally dependent on your protocols and your service. So last thing, I'm really looking at toxicology, the assessment and management of a patient with suspected poisoning or overdose. If it's outside of some of your things we routinely see, the overdose people normally think of as things of narcotics. Narcan administration, there's some debate on that. There's a wide variety. There's individuals and police departments and things of that nature that have Narcan, and they give patients Narcan before EMS might arrive. Some services are looking into moving away from giving Narcan in large doses. They usually stick to 0.4 to 0.5 in little increments and wake them up and kind of do reverse them in a more kind of a therapeutic or slower approach. It's not just boom, here's your whole amp of the 2 milligrams, that kind of thing. That tends to cause greater issues. People tend to have they'll vomit more often, things of that nature. So if one of the other options from an overdose perspective is to go ahead and look into airway management, possibly administering a paralytic if they're significantly sedated from their overdose of narcotics, for example, and then go ahead and administer or benzo and go ahead and administer a paralytic, intubate them, and then transport them to the hospital. And there is some evidence from some data and some studies out there that detoxing and kind of progressing through that stage over a 24 to 48 hour period is better than arriving on scene and boom, here's your Narcan and kind of throwing them out of it. So every situation is different. It's one that you kind of have to kind of take from a provider approach and not treat them all the same, and kind of you have a wide variety of options there that you can aid the patients with, that kind of thing. So and other than that, from a benzo perspective, we have moved away from the pre-hospital use and routine administration of Romazicon, mainly because if the patient has taken too many benzos and we administer Romazicon and we block those receptor sites, and they should have a seizure from the kind of withdrawal from the benzos and blocking all those sites, and then we can't stop it with benzos, because if we block all the receptor sites with Romazicon, we're kind of stuck there. So most places have moved away and gotten that out of their protocols. They don't keep it anymore for that main reason. So most places are not doing that anymore. And then out of the kind of normal stuff that we see, you just want to, your best friend when dealing with poisoning is going to be poison control, because literally at their fingertips, they type it in, they have all the resources that you need. So if you arrive on scene and someone has ingested a certain substance or a product or anything like that of some kind, or been exposed to something, poison control is your best friend. They will help you. Like I said, they got everything at their fingertips. They can tell you what treatment approaches might be best, what to watch for, what can be some signs and symptoms of issues that can, things that they might have been exposed to or ingested, etc. So just always have that number available, either in the truck if you have a crew cell phone or something like that, or a crew phone on your ambulance. If you don't, it might just be a good idea in your region to just get poison control's number, or if you have something with the hospital, something like that, just have it in your phone and have it available, because it can help you tremendously. So coming from a flight nurse perspective, I might want to know to do more than what is the standard paramedic scope of practice. Will there be questions on the NREMT test that give an answer which is correct in a way, but the wrong answer for the test because it's beyond the medic scope of practice? So Ryan had that question. So basically, this is kind of the hard part about this class, in the sense that we have a lot of individuals who work in the EMS realm and might even be ALS providers already, or especially from the air medical perspective, where you're doing advanced procedures, advanced protocols. You're over here, you might be able to do central lines and chest tubes and escharotomies and things like that, and things that you might be able to intervene on, but it might not be in the standard scope. From the most part, that's why I try to preface this class with you might look at this and think, well, this is not very advanced, and unfortunately, it's not, because what this class is basically preparing you for is officially entry-level paramedic knowledge, which is what the NREMT exam is going to focus on. So this is not going to be FPC or like CCPC or your critical care medic or your flight paramedic board cert questions. These are going to be entry-level paramedic knowledge, which is obviously it's not BLS or anything like that, but it is not your critical care structure. So from that approach, you have to think that this is not you're not running it from a critical care perspective. So I really don't know how to explain it other than that, in the sense that if you have an answer that might be for the NREMT test, they can give an answer which is correct in a way, but the wrong answer for the test is beyond the medic scope. So yes,
Kyle,
if it's
okay?
Yeah.
I think to elaborate on that question, just, if there is something about, say, vasopressors for septic shock,
Right.
that might be a critical care paramedic concept that isn't covered in the basic, licensure exam. Should I steer away from those types of answers, knowing that they're not meant to really be for the basic paramedic? Even though I myself might be like, yeah, I want to give vasopressors to this patient. It's not the answer that's technically correct for the exam. Does that make sense?
Yeah. So it's not. I wouldn't say that obviously pressures are definitely within the standard paramedic scope. It is something that when you answer questions, for example, that question would be, you want to start with simple, then progress your way through. So if your answer first was, push dose pressors with, something else, and it basically ignored, administering a fluid bolus first, where the other one was O2 IV, make sure they're all hooked up to the monitor, give them a fluid bolus of this much, and then progress to a vasopressor if needed. That would be the proper answer. So you want to come at it, because basically National Registry is pretty generic in their approach of how they word their questions. It's multiple choice. So it's not, at this point, there's not any select all that apply type of questions like you might have seen from your nursing boards, et cetera, and some other type of board exams. So it is not one of those. They typically put things in there that are grossly, if it's wrong, it's usually grossly negligent. But there are some of those scenario-based questions where two answers, you can really argue either one. It's kind of which one is most right in that scenario. So the approach I would take is what approach or what treatment option kind of progresses from a initial stabilization and then up to an advanced side. And when in doubt, you want to start with that kind of initial stabilizing approach. And like I said, it may not be a basic level answer, but it would be something that I wouldn't maybe necessarily jump to totally advanced right away, because they're asking you to look more at a initial basic stabilizing before you jump to.
Okay, yeah, that makes sense. I appreciate it. Thanks.
So yeah, and one other thing from a registry perspective for everybody is that typically registry does not deal in a lot of medication dosing. Outside of AHA, standard ACLS guidelines, things for like running a cardiac arrest. If you're going to administer amiodarone, it's 300 then 150 according to AHA's guidelines, that kind of thing. So adenosine 612, whatever it may be. But for the most part, you might see some there, but registry tends to avoid putting dosing on the exam. The main reason why is because they know every service and medical director and protocols are different. So they avoid a lot of dosing, but they put what medication would be appropriate, most appropriate to treat this patient when they're in stable SVT, or all their vitals are stable except they're, you know, in SVT at 218. Well, then it would be adenosine, you know, for example, would be the most appropriate medication to treat that. It's not going to ask you really dosing where, you know, they might have some other medications on there like, you know, rocuronium, which is obviously, it would be an obviously incorrect statement or answer for an SVT patient, something like that. So they tend to avoid the dosing only because of that, but they will, you will need to kind of know, obviously, what medication is appropriate or what class of medication to kind of look to. You know, if you there would put out, you know, from a hypotensive, say, septic shock patient, you might give fluid management and then progress to a vasopressor. And then, but they wouldn't, if they do put some dosing in there, typically it would be, if it's wrong, it's going to be grossly outside of a normal range. But like I said, they try to avoid that so you don't get caught in that trap of them trying to, you know, because that's easy for people to argue because, well, my protocols say this and this is different from this. And so it might be class of medications or a type, not necessarily the dose type. So hopefully that may help in there as well. But
it did. Thank you.
All right. That was pretty quick. This is, again, one of those where a lot of this info, like I said, is stuff you guys already deal with on a regular daily basis that everybody does and has a lot of knowledge about. So again, if you guys have any questions, feel free. Let me know. If not, we'll obviously it's recorded. We'll get it posted in there for everybody who to watch later. So if you guys have any questions, I'll get them answered. If not, we'll jump off here and look to finishing up first week of kind of stuff. So for the 275 folks when they're with their stuff, and then obviously the 276 folks, you guys are kind of at your own pace. I know we've touched on the medical side, and just a heads up, the stuff we touched on today, this is in module 1 of the 275, where the hybrid folks. This is officially unit 8 of the SDL or the 276 module. So just fair warning for a little bit of difference there. So just keep that in mind as well, depending on which cohort you are in. So if you guys got any questions, I'll hang out for a minute, but if not, we'll hopefully see you on the next one. And as always, if you got anything, feel free to let me know. You can call, you can email. Email is usually quickest. Like I said, it comes to my phone all the time. So have a good rest of the day and have a good week.